I hope you enjoy this in-depth video by Drs. Robert H. Osher and James Osher, Understanding the Drop Nucleus, brought to you by Haag-Streit USA.
The specter of nuclear loss haunts every operating theater in which cataract surgery is performed. But the essential question remains unanswered. Why does the nucleus fall backwards? This study was designed to investigate the causative factors so for the first time we can truly understand the etiology of the dropped nucleus. We prepared a series of pig and human cadaver eyes by placing a single plain incision at the limbus. An OVD was injected into the anterior chamber, followed by removal of the iris. The anterior capsule was stained with vision blue, and a capsulorhexis was performed. Hydrodissection was followed by careful removal of the epinucleus. The posterior capsule was widely opened with a 22-gauge needle through the pars plana. Our first hypothesis was to test the common belief that the nucleus drops because of gravity. A nuclear quadrant is maneuvered over the vitreous. To our surprise, the nucleus consistently remains perched upon the anterior hyaloid face. Next, we place the nucleus into the midvitreous. We are even more surprised to observe that it, too, remains suspended. If gravity was the essential factor, the nucleus would have descended onto the retina. Our second hypothesis was to test my long-standing belief that the nucleus drops because of the high infusion pressure created by a high bottle. We are shocked to find that even when the bottle is raised to the ceiling, the nucleus barely moves. When the infusion is placed behind the nucleus, it also fails to launch the nucleus forward. While an ophthalmologist may have been astonished, the engineers were not surprised, since they explained that pressure is equally distributed like gentle hands surrounding and securing the nucleus. The engineers then claimed it must be a pressure gradient, which was hypothesis number 3. After all, nuclear chips commonly head for the incision, following a path to atmosphere which can easily be reproduced in the laboratory. We designed a model to create a high pressure in the front of the eye, expecting that when the posterior capsule is suddenly opened, the nucleus would abruptly vanish. The bottle is up, the infusion pressure is high, the posterior capsule is suddenly ripped, and nothing happens. Wrong again. Hypothesis number 4, it must be mechanical. Can the unsuspecting surgeon inadvertently shove the nucleus backwards? The nucleus is suspended over the open posterior capsule and repeatedly nudged by a chopper or an INA tip. Surprisingly and mysteriously, the nucleus remains in place. Hypothesis number 5, chamber fluctuation or surge. A high aspiration rate can pull vitreous forward or empty the chamber, while a high vacuum at occlusion break will cause surge. Violent forward movement of the vitreous seems to allow the nucleus to fill the void, and for the first time, we watch the nucleus disappear. Yet when we turn down the aspiration rate in vacuum, as in slow motion phaco, the nucleus can actually be emulsified on the anterior hyaloid face. A more stable chamber with a more quiet intraocular environment is more conducive to retaining the nucleus in the anterior segment. Hypothesis number 6, turbulence matters. After a large tear is made in the posterior capsule, the nucleus is being emulsified with torsional ultrasound. When the mode is switched to longitudinal ultrasound, the nucleus is immediately blown backwards. While we could not repeat this result in every eye, notice the marked difference in turbulence as the surgeon alternates between torsional and longitudinal ultrasound. Finally, it is time to evaluate the role of the vitreous, the 7th hypothesis. Recall that the nucleus remained over the open posterior capsule, defiantly resisting gravity. An injection of triescence, a non-preserved triamcinolone, reveals a once invisible vitreous gel supporting the nucleus. Recall that the nucleus resisted gentle shoving. When triamcinolone is injected, a supportive bed of vitreous is revealed. We have shown that the nucleus can be emulsified on the anterior hyaloid face, but if a pars plana vitrectomy is performed, the nucleus falls backwards. In this eye, the chamber is deliberately drained by high aspiration rate and vacuum, causing the vitreous to prolapse toward the incision. The nucleus visibly rotates but doesn't fall. Why? Because of the vitreous suspension bridge that, if tugged upon, demonstrates its supporting role. We found that the composition of the vitreous also plays an important role. In the elderly eye, the vitreous is syneretic, with a higher water content, so the nuclear quadrant can more easily fall backwards. Note the lack of triamcinolone staining in this eye of a 90-year-old person. By contrast, the vitreous in the young eye is more formed, and it will support the nucleus with its structure that is clearly demonstrated with triamcinolone. Incredibly, it can also support a rock, unless a syneretic area or an iatrogenic vitrectomy provide an easy path of descent. Without vitreous, this graphic experiment shows that gravity does in fact prevail. Can we create a supportive vitreous analog? We remove the remaining vitreous and then inject OVD. Then the same rock is placed in the anterior chamber. Amazingly, the rock stays suspended over the OVD. Yet as soon as the OVD is removed, the rock falls like a rock. Okay, we don't usually work with cataracts, so let's perform a pars plana vitrectomy, tear the posterior capsule, and even when using the safest torsional ultrasound with low parameters, the nucleus drops. Since there is no vitreous present, not only can the nucleus fall backwards, but if the eye is inverted, the nucleus will fall forwards. The OVD is injected, the eye is re-inverted, and the nucleus stays magically suspended on a bed of Helon 5. An additional vitrectomy confirms that there is no vitreous, yet we are able to complete the slow-motion phacoemulsification over the OVD. So what have we learned? Once again, to challenge the accepted. The vitreous is the enemy. Those immortal words of Dr. David Kasner, the father of vitrectomy, have been passed from teacher to student for more than 3 decades. Yet when the posterior capsule is torn, it is the vitreous which serves as a safety net, behaving not as the enemy, but as the surgeon's best friend.